I'm going to begin this morning's program by spending about 55 minutes giving you an overview of how MR imaging can help us as we try to sort out a number of processes that involve synovium blind articulations. So as always, let me start with some general, simple anatomy. The drawing on your right shows a typical construction of a synovium blind articulation. Two bones separated by a joint cavity. The ends of the bones are colored in blue, representing cartilage, which in most areas of the body is articular cartilage, or is hyaline cartilage, not fibrocartilage. There are a few exceptions to that rule. Shown in green surrounding the joint cavity is the fibrous capsule, under which we see the deeper portion, in red, the synovial membrane. So basic construction of a synovium blind articulation. At the corners or margins of the articulation, we have the situation in which the synovium is applied directly to bone. This explains why we develop marginal erosions of bone when we're dealing with a process associated with synovitis. So the detection of erosions at the margins of a joint tell you that the basic pathology of the process is synovitis, whether you see those erosions by plain film, CT, or MR imaging. The process may be rheumatoid arthritis, a seronegative spondyloarthropathy, or infection, but you've taken one step toward accurate diagnosis. Here, with histologic analysis, we see these marginal regions where synovium abuts bone. In some joints, we have another structure, sometimes centrally located, made of fibrocartilaginous tissue called a meniscus. There are a number of joints that contain such a meniscus. We'll be spending time during this course on some of these articulations. We'll discuss the meniscus of the knee, illustrated at the top right. We'll talk about the triangular fibrocartilage of the wrist. But you can see on the list that there are other joints that contain pieces of fibrocartilage important to the function of that joint. In MR imaging, we have many choices, one of which is whether to use contrast agent. We can deliver that contrast agent in two ways. An intra-articular injection, so-called MR arthrography, direct technique. As I mentioned to you yesterday, we use this technique in a limited fashion, but mainly for glenohumeral joint instability and the assessment of the labrum of the hip. And during this course, we will address in great detail the role of MR and MR arthrography with those particular problems. The second way we deliver the contrast agent is in the intravenous route. Here, what we suggest through the rationale is by introducing the contrast agent, it seeks out the synovial membrane. But over a period of time, it leaks into the joint. So there are two phases, really, of this particular procedure. If you want to stress what's going on in the synovial membrane, you must image fairly quickly after the intravenous injection. If you want to use the joint opacification, you do indirect MR arthrography. You want to delay your imaging until the contrast has entered the joint. We use intravenous contrast material, particularly in the assessment of joints when looking for synovitis. Here at the top, a proton density fast spin echo image, a distended joint, complex appearance, and at the bottom, we can see with a bright signal areas of extensive synovial inflammation. Once again, it may not give us the specific diagnosis, but it gives us some idea of what is synovitis and what is fluid. Here, for example, the bright stuff is the synovitis, and the fluid is seen as lower signal on a T1-weighted, fat-suppressed image. Let us look at some of the general abnormalities that affect joints, beginning with a joint effusion. With conventional radiography, we detect joint effusions by looking for displacement or obscuration of fat planes located around a joint. The classic example to show you would be the lateral radiograph of the knee. where we measure a distance between two fat pads, one above the patella, another not well shown here along the anterior aspect of the femur. And if we measure this and it's greater than 10 millimeters in width, we suggest joint effusion or synovial tissue, or both are present. But it's of interest, when we did an experiment on this, it probably takes 6 to 8 milliliters of fluid to produce a positive radiographic sign of a joint effusion in the knee. So this isn't very, very sensitive. Even in the early days of MR imaging, and here is an image from the early days, when we used conventional spin echo imaging, we were impressed with how well we saw fluid. In this example, not only did we see the joint effusion, which is on your right, we could see the effects of an injury, a bone contusion, both in the femur and tibia. In the next lecture, I'll be covering in great detail what these bone contusions are, what they mean. But here we found that there was, with standard MR imaging, we were able to detect edema and fluid, even if there was less than 1 or 2 milliliters of fluid within a joint. Synovitis is something that we can study with MR imaging, and the signal intensity characteristics of the process will vary according to the tissue that is within the diseased synovial membrane, with 4 major types of tissue: fat, cellular fibrous tissue, acellular fibrous tissue, and fibrous nodules. What we look for when we study the diseased synovial membrane is not only the signal intensity of what is in there, but this hypertrophy, this irregularity, the fronds and diverticuli that extend into the lumen from the enlarged synovial membrane, well shown in this particular case. In some situations, we have blood within a joint. We call this a hemarthrosis. The detection of a hemarthrosis is not specific, as there are several disorders that present in this way: injury, hemophilia and other bleeding disorders, pigmented villonodular synovitis, certain neoplasms such as synovial hemangioma, neuropathic disease, crystal deposition disease, anticoagulant therapy, chronic renal disease. The list goes on and on. In the stages of a hemarthrosis, chronic stages, there are some specific MR imaging features that allow us to suggest chronic bleeding has occurred. The major one of which is darkening of the synovial membrane owing to the presence of hemosiderin deposition. This is an example of a young adult with monoarticular disease of the knee, in which we can see extensive infiltration and dark signal within the synovial membrane of the joint, as well as within a small popliteal cyst. Based on age and the fact that this is a monoarticular process, the best diagnosis is pigmented villonodular synovitis. Here is another young adult with polyarticular disease, and again, the major finding is the hemosiderin deposition around the joint. Best diagnosis in this case would be hemophilia. So the finding of hemosiderin deposition is not specific, but based on clinical information, you can usually narrow down the process. It's of interest when you look at the knees in patients with hemophilia who have extensive hemosiderin deposition, as shown here. One of the sites that is preferred for that deposition is the intercondylar notch. Now that's interesting because on a plain film we look for widening of the intercondylar notch as a feature of hemophilia. Here is the MR imaging correlate of that radiographic finding. And another example of hemophilia, which I like, we can see that the ankle is involved, a common site of involvement in hemophilia, but also involvement of the posterior subtalar joint. For years I have thought if you have a disease that predominates in these two joints in a young adult, hemophilia is a terrific diagnosis to make, because these are weight-bearing joints, and these two will in fact undergo bleeding into the joint. In some situations, we have both fat and blood within a joint. We call this a lipohemarthrosis. And although the MR imaging appearance varies, this is one of the characteristic patterns of 3 layers and 2 fluid levels shown here. I'm going to not talk more about that now, as we'll cover the topic later today. When we have fluid in the joint or inflammatory tissue, there is elevation of intra-articular pressure. The body tries to compensate for this by creating or enlarging an opening between the joint and a surrounding synovial sac. That sac enlarges or distends, and a synovial cyst is created. The most common site that we see these cysts is behind the knee, the so-called popliteal cyst. The fluid takes a complicated course from the joint around the posterior capsule that serves as a ball valve mechanism, and then, still complicated, enters a bursa intimate with the medial head of the gastrocnemius and the semimembranosus tendons. So this then the classic popliteal cyst. The popliteal cyst is a manifestation usually of something wrong in the joint. So you have to address what is in the joint that's producing this particular cyst. Large cysts, the most common cause is rheumatoid arthritis. Small cysts, the most common cause is an internal derangement of the knee. MR imaging, of course, provides excellent delineation of these cysts. Here's a classic lobulated one on a fluid-sensitive sequence. These cysts may dissect, remaining contained, or they may rupture. And here's an example of escape fluid behind into the calf. Sometimes they rupture in a retrofemoral location. The symptoms are somewhat different. When they extend downward like this, the clinical findings resemble those of thrombophlebitis. Synovial cysts occur in children, although they're said to be not so common. And one of the interesting aspects in children, some of these are non-communicating. They do not communicate with the joint, so their pathogenesis is not quite clear. An example of one shown here. With MR imaging has come the ability to recognize fluid collections. This has led to difficulty applying names to them. We use terms like synovial cyst, ganglion cyst, meniscal cyst, perilabral cyst. Differentiation among the pattern of the cysts is probably best left to a pathologist and not to a radiologist. But to give you some ideas of the classic fluid collections we see, the meniscal cyst shown here, we'll talk more about this another day during the course. These cysts may arise from tendon sheaths or labrum, and these are the 2 examples that we will cover elsewhere in the course. A perilabral ganglion cyst about a torn acetabular labrum, and a perilabral ganglion cyst about a torn labrum of the glenoid. These cysts may arise from ligaments. Best documented perhaps in the cruciate ligaments, we call these ganglion cysts. We've seen a number of these. Here's an example of one. The main differential diagnosis is cystic degeneration of the cruciate ligament, and we'll be addressing that elsewhere in this course. We can see bursitis. Now, bursae are generally found in the human body over bony prominences, particularly in subcutaneous locations. Small amounts of fluid within a bursa are considered entirely normal. Large amounts may indicate bursitis. The causes of bursitis include rheumatoid arthritis, the seronegative spondyloarthropathies, crystal deposition diseases, including gout, trauma, and very importantly, at the bottom of this list, infection. Septic bursitis is something you always have to keep in mind, okay, particularly in the olecranon bursa and in the prepatellar bursa, which are classic sites of infection. The first example I ever saw with MR imaging of bursitis, I now show you. It's many years ago. This is conventional T2 weighted image, and I was impressed with how distended this subacromial subdeltoid bursa was. As we'll talk about later, that is in fact one of the largest bursae in the human body. As you look at the signal intensity here, it was also impressive how we could see a background of bright fluid on a fluid-sensitive sequence and well-defined nodules of low signal. These nodules represent rice bodies, and they're characteristic of processes that produce chronic synovial inflammation. The classic disease is rheumatoid arthritis as present in this particular patient. But I would remind you again, when you see rice bodies, consider also tuberculosis as a possibility. Here's an example of septic bursitis in a favored location, the prepatellar bursa. Here we see a T1 weighted image with low signal in the middle of the bursa and then a lining of slightly higher signal. Here with gadolinium, the highlighting or bright signal of the synovial membrane, septic bursitis. Tenosynovitis is also well discovered with MR imaging. In this example of tenosynovitis involving the flexor tendons, we can see the lobulated distended disease of the flexor tendons with complex signal intensity on T1 and T2 weighted areas of fluid certainly seen. Following intravenous gadolinium, we can see enhancement in areas of the synovial membrane and a lot of fluid present within that tendon sheath. Intra-articular bodies can also be assessed with MR imaging, but MR imaging is not very sensitive to this task, unless, in fact, there is fluid within the joint. The causes of intra-articular bodies are any process that leads to disintegration of the articular surface. Particularly things like trauma and osteoarthritis would come to mind. The bodies are composed of cartilage alone or cartilage and bone together. Rarely they are composed of bone alone. The bodies may remain at their site of origin or become slightly displaced, as I show you in this drawing. What may occur in some of them is that they dislodge and become free or loose within the joint cavity. If that's the situation, they migrate around the joint, seeking out specific locations, more about that in a moment, and they may additionally become embedded in the synovial membrane, where they evoke a secondary response of synovitis. When we look for intra-articular bodies with any imaging technique, we look to all portions of the joint. But in particular, we look at recesses and dependent portions of the joint. In the glenohumeral joint, we look in the area of the subscapular recess, and in this case also in a dependent posterior aspect of the joint. In the elbow, we look in the areas of depression on the anterior and posterior surfaces of the distal humerus. The largest site or depression is that obliquum fossa, and here we see a body that is deposited within it. In the knee, we have to search far and wide because of the large joint. These bodies can lodge in distant recesses, as shown here, in a superomedial aspect of the knee. And indeed, as you know, they may migrate from the joint proper into a popliteal cyst. These bodies, derived from disintegration of the articular surface, may become large and multiple. And when they look like this example, one of the diagnoses that comes to mind is idiopathic synovial osteochondromatosis. But when you're dealing with a process of secondary synovial osteochondromatosis, as in this case, some of the hints that would help you say it is secondary rather than primary is that the number of bodies, although large, is not countless, which may be the case, as you'll see later, with idiopathic synovial osteochondromatosis. Also, in the secondary variety, as shown here, the bodies are of variable size, whereas in primary, they often are of the same size. So this is secondary synovial osteochondromatosis. Where MR imaging has a clear advantage over arthroscopy is in the assessment of the subchondral bone. Now, I'll go through transient painful marrow edema very quickly because we already have addressed this in several talks. We see this transient edema in the subchondral bone. But as Dr. Fizar told you yesterday, that in many of these cases that we previously had called idiopathic, careful assessment, especially of the subchondral bone, will reveal an insufficiency fracture, as shown by the yellow arrows in this case. The problem with the identification of these is they can be small, and they can merge, it seems, with the dark signal of the subchondral bone plate. And that is why I say if you see even thickening of that dark signal, it may be an insufficiency fracture just below the subchondral bone plate. We've talked a little bit about how this edema may migrate from one joint to another, or as shown here, from one part of a joint to the other. Now again, this may be stress changes, I don't know, it may be idiopathic, but you will see this happen, especially in the lower extremity, and most characteristically, I think, in the knee and the bones of the foot. And we talked a bit about reflex sympathetic dystrophy syndrome and its pattern of marrow edema. Generally, yes, associated with soft tissue and muscle findings, but sometimes not. We look for such things as a bone-within-bone appearance and speckled alterations in marrow signal to suggest, in fact, that we may be dealing with an aggressive osteoporosis. Marrow ischemia, of course, is something that MR imaging is very good at, and of course the early reports, particularly with regard to the femoral head, were very encouraging. The classic appearance of osteonecrosis or a bone infarct are linear serpentine-like shadows of low signal and, very importantly, areas of entrapment of fat. Now, in the second talk today, I'll show you what the acute ischemic event looks like on MR. It's much more of a diagnostic dilemma. But in the chronic cases like this, MR imaging is sensitive and specific, as illustrated here. And we talked yesterday about this condition of spontaneous osteonecrosis about the knee, previously called SONC, now representing in most cases an insufficiency fracture. Here is the classic example on the weight-bearing surface of the medial femoral condyle. Seen in older persons, more often a woman than a man, who have an acute onset of knee pain. They can remember the day, the hour, the minute the pain began. Now, why that is, I'm not sure. Is it the fracture? Is it the collapse that may accompany it? I'm not sure. But this is typical. And usually when you see these findings, the meniscus and the cartilage in the ipsilateral femoral tibial compartment is abnormal. So the cushions are gone, and there's more stress placed on the subchondral bone. We do see this same process in other areas of the knee. Second to the medial femoral condyle is the lateral femoral condyle, and in third place, shown here, is the medial tibial plateau. Here an example showing you again an insufficiency fracture within the subchondral bone. Now you know about spontaneous osteonecrosis. Here is not so spontaneous osteonecrosis about the knee, because you see any process that injures cartilage or injures menisci or both can lead to insufficiency fractures. In this example of calcium pyrophosphate disease, the findings in the medial femoral condyle are identical to what has been termed spontaneous osteonecrosis about the knee. Well, let's turn our attention in the second half of this lecture to specific disorders. We'll begin by talking about rheumatoid arthritis and the seronegative spondyloarthropathies, classically psoriasis, Reiter's syndrome, and ankylosing spondylitis. In all of these diseases, the imaging features relate to early and sometimes profound synovitis. distension of the joint, thickening of the synovial membrane, hyperemia in that synovial membrane, and an enlarging joint effusion. Bone abnormalities typically include marginal erosions, as we talked about, and the development of enlarging cyst-like lesions within the subchondral bone. Those cyst-like lesions, which rheumatologists call geodes, they may contain fluid or abnormal synovium or both, and they can become quite prominent. Here's an example with conventional radiography showing progressive marginal erosions of rheumatoid arthritis, and in a different patient, I show you what these look like with MR imaging. Yes, in the years ahead, I think MR imaging will become the modality of choice by rheumatologists to assess rheumatoid. It's already happening. But I would caution you that I think sometimes, as I mentioned yesterday, telling marginal erosions of the metacarpal heads, even the phalanges, the metatarsal heads, is difficult because of the normal flattened areas and depressions that occur on those structures. In this case, there's no question we're dealing with large erosions of bone. And that search for rheumatoid arthritis using MR imaging will include intravenous gadolinium. Here an example with T1 weighted imaging, T2 fat suppressed imaging in the middle, and gadolinium enhancement showing you, particularly with the gadolinium, evidence of synovitis. Okay? But there are problems here. How much enhancement is abnormal? That has not been well pointed out in the literature. Will measurements help us with regard to the thickness of the synovial membrane that we see? And the other problem I see is how many joints do you search in? How many sequences or planes do you use for each joint? Do you do both extremities together, or do you do one? I think all this will have to be discussed, because some of the times when we do this, we end up with an incredible long series of images, many series, I should say, and multiple images that become very difficult to evaluate. So I think changes will occur in the protocols for the assessment of rheumatoid arthritis. The diseased synovial membrane in rheumatoid arthritis can take several different forms. Not well recognized, but certainly occurring in rheumatoid arthritis, as in osteoarthritis, is fatty infiltration of the synovial membrane. This is a secondary lipoma arborescens. It's not the primary variety. I'll show you that a little later, but this is secondary. So this will occur in rheumatoid arthritis as well as in osteoarthritis. A second pattern is fibrovascular proliferation, a feathery appearance to the diseased synovial membrane, with signal intensity generally intermediate in nature, as shown in this example. And then the third pattern of chronic disease is fibrous nodules. And these become discrete, forming in the synovial membrane and then being pinched off, becoming sometimes free or loose within the joint cavity. Each one of these resembles a cartilaginous or osseous body. So that's the major differential diagnosis. One of the findings that we occasionally see in patients with rheumatoid arthritis and other inflammatory diseases is lymphadenopathy. I've seen this most typically in the posterior aspect of the knee. I've seen it also most commonly in juvenile rheumatoid arthritis as opposed to adult onset. This is an interesting chain of lymph nodes, and I'm sure many of you, as you look at this slide, are saying, I see this every single day in my practice with internal derangement. So lymphadenopathy in this location may not have clinical significance. It is a very common finding. The subchondral cysts that occur in rheumatoid and related diseases may become large, as shown here. This is especially true about the joints in the lower extremity and in men rather than women. Sometimes, as in this particular case, these areas become so large on plain films they resemble tumors. With intravenous gadolinium, we can see the enhancement around the lining of this fluid-filled collection, and indeed we can see some additional abnormalities on the tibial side of the joint. In psoriatic arthritis and Reiter's syndrome, there is a peculiar alteration that may occur in the early part of the disease, characterized by marrow edema. I've seen this a number of times, particularly in psoriasis and especially in the foot, as shown here. Now, I find this interesting, first because I don't see it often in rheumatoid arthritis, and second because part of the morphology of the psoriatic process shown here, as opposed to the rheumatoid process shown here, is the presence of bone proliferation. And that's nicely shown in the radiograph. So perhaps the marrow edema is the stimulus that produces the bone proliferation here on an MR. We can also see these mouse ears about a diseased interphalangeal joint. So marrow edema in the seronegative diseases. In rheumatoid arthritis, and in fact in all of the synovial inflammatory diseases, there are a number of complications that may occur. Malalignment, synovial cyst formation, fistula or sinus tracts. In fact, there's an entity, sinus tract rheumatism or fistulous rheumatism, where we see the pannus on the skin surface, particularly in the foot. And periarticular injury, I'll give you an example. People with rheumatoid who have involvement of the shoulder often develop tears of the rotator cuff. Well, here's an example that I show you of a patient with rheumatoid arthritis with extensive wrist involvement who went on to develop a complete tear of one of the flexor tendons. So periarticular injury may occur. Soft tissue nodules are a well-known feature of rheumatoid arthritis. There's not a lot written about their appearance with MR imaging. We have some anecdotal experience, a number of cases like this one where rheumatoid nodules looked a little bit like abscesses or necrotic tumors when studied with intravenous gadolinium. Here we can appreciate the enhancement in the periphery of the nodule and the irregular low signal centrally. Now, this could also be a liquid-on bursitis, but it was a rheumatoid nodule in this case. As you've already heard, one of the complications that we see in rheumatoid arthritis-related diseases shared by patients with osteoporosis or those who've had a radiation are insufficiency fractures. And it was of interest that insufficiency fractures of the pelvis were not reported until about 20 or 25 years ago when people began reporting them. And now we recognize them. I imagine before that I missed a lot of these because they can be subtle on conventional radiography. As shown at the top right image, the typical thing we look for with the insufficiency fractures of the sacrum are bands of sclerosis on a plain film. They are often oriented in a top to bottom manner, and you can sometimes see the breaks in the cortex as well, but often there is gas overlying this area, so I'm sure we miss a lot of these. There are other areas, as Dr. Vizar noted, about the pelvis that are classic sites of insufficiency fractures, including the parasymphyseal bone, where they can look like chondrosarcomas. Also the pubic rami, the iliac crest, certainly the femoral necks, even the femoral heads in a subchondral location. In this example, in the bottom image, we can see that the ilium is also involved. So in some of these cases, the marrow alterations are not confined to the sacrum, but are also seen within the ilium. Let's turn our attention now to the MR imaging features of some of the crystal-induced arthropathies. We begin with gout, which is generally a clinical diagnosis and not an imaging diagnosis. Here, the disease, in terms of pathogenesis, begins as crystals are carried to the synovial membrane by the bloodstream. They evoke a synovitis and a large joint effusion. This is the inflammatory response to those crystals. What occurs next is that these crystals are released into the joint cavity. And once there, they are taken up by the cartilage, extend through the cartilage to reach the subchondral bone. This relates to the succulence of articular cartilage and its ability to absorb crystals from the joint fluid. So as they travel transchondral, and as they reach the bone, they destroy the cartilage. But one of the interesting features that you all know is that on conventional radiography, gout, as compared to rheumatoid, may not be associated with joint space loss. And it's shown here why, because the destruction of the cartilage is focal, and around areas of destruction, the articular cartilage may be preserved. Gout also produces tumor-like deposits in the soft tissue, often periosseous, that erode the bone, sharp marginated erosions, and lead to a very characteristic bone proliferation that we call the overhanging edge. So these are the radiographic features of the disease, and they're well displayed in a typical example, in a typical site. Overhanging edge shown by the yellow arrow, the sclerotic marginal erosions shown by the black arrow. So very, very characteristic. Now MR imaging comes along, and what does this disease look like with MR imaging? Gout is one of the disorders that can lead to areas of low signal even on fluid-sensitive sequences. So in combination or acellular fibrous tissue, hemosiderin, even amyloid, this is a process that may be associated with areas of persistent low signal. This is widespread gout with involvement of the knee with a large mass behind the knee, which on a fluid-sensitive sequence has complex signal intensity, areas of low signal mixed with areas of high signal. So gout would certainly be a diagnosis to consider. It's not the only manifestation that we see. One of the other characteristics that has been reported and I have seen in this disease are pericruciate deposits. Why gouty deposits occur about the cruciate ligaments is not entirely clear to me, but they can produce masses, they look like tumors almost, sticking into a fluid-filled joint as shown here. And if you were to take a case like this and do a CT, as was done in both knees in this patient, you see some densities that look like calcification. Now, some of these are calcified tophi. Others have suggested that the CT values of the urate deposits themselves can look very much like calcification. So some of these tophi are not calcified. This is just a manifestation of the density of the tophus itself. Now, as you know, there are some new dual energy CT techniques for identification of gout. Now, to expand on the MR imaging appearance of this particular disease, I want to call your attention to another pattern that I have seen, which is this very peculiar erosion of bone. You see these well-defined erosions with areas of intermediate signal extending into the subchondral bone. And I've seen these mainly in the tibia about the knee. This patient had gout with evidence of the disease elsewhere. So maybe these dissect along the cruciate ligaments, I'm not sure. Gout loves the extensor mechanism of the knee. So whenever you see bizarre processes involving the patella as shown here, or in fact areas or bizarre processes of the quadriceps tendon or the patellar tendon, you want to think of gout. Calcium pyrophosphate crystal deposition disease, of course, is common, especially in elderly persons, and we know it best as chondrocalcinosis, defined as cartilage calcification. So clearly, those deposits within the articular cartilage can appear on MR images as a speckled pattern of low signal. It is remarkable to me how often we miss CPPD deposition on MR. I've had some examples where the cartilage doesn't look perfectly good on the MR, and then the plain film shows up, and there's widespread chondrocalcinosis in the articular cartilage. And similarly, the menisci look pretty good, and then the plain film tells me there's widespread chondrocalcinosis in the menisci. So sometimes we miss this particular crystal, or these crystal deposits completely. I do not think MR is sensitive to calcium pyrophosphate crystal deposition. But these crystals are not isolated to cartilage, and they occur in other structures, and I would remind you of that with this simple case in a cadaver that shows that the crystals occur not only in fibrocartilage, shown here and here, but they occur also in hyaline cartilage and in ligaments. And the involvement of these interosseous ligaments in the proximal carpal row is typical. Now, we're going to talk about these ligaments in great detail later in the course, but not for crystal deposition. This area in particular, sometimes the deposits occur here without deposits within the adjacent fibrocartilage. So always look here for areas of calcification. Because of the deposits of calcium pyrophosphate crystal deposition in tissues other than cartilage, bizarre appearances may occur or appear on the MR images. You know, what we often do in our research is section cadaveric joints. And these are derived from persons who were elderly at the time of death, in large part. It is remarkable how frequent calcium pyrophosphate deposition is. So figures that say 25 or 30% of persons over the age of 60 are totally incorrect based upon our experience in the cadavers. It's 70% or even more than that. So we see examples like this where we get calcification in tendons, and the gastroc tendons in particular. MR image, it really is bizarre. You wouldn't know exactly what's going on. And we see examples, not infrequently, where the cruciate ligaments have calcium in them, as shown here. So be aware that if you're dealing with calcium pyrophosphate disease, widespread calcium deposits are expected. And we can even look up in the neck and see this manifestation of calcium pyrophosphate. I'm sure you've all seen this on CT exams all the time. This is the transverse ligament of the atlas that extends around the odontoid process. The patterns of deposition here can include mass-like areas that impinge on the spinal cord that look like tumors. And what we have found in this location is because these deposits affect the transverse ligament, and that ligament is intimate with the posterior aspect of the odontoid process, these patients are prone to develop odontoid fractures, even with minor injuries. And here's an example excuse me, taken from several that we reported of pathologic fracture through the base of the odontoid process. Now, I'm going to talk more about calcium hydroxyapatite crystal deposition when we talk about the shoulder, but I wanted to point out one particular aspect of the disease. We all recognize it as something that occurs in the tendons of the rotator cuff. But as I will show you, it is the movement of the calcification from there elsewhere that produces the pain. And the elsewhere can be superiorly below the floor of the bursa or into the bursa. It can be medially to the myotendinous junction of the involved muscle, or it can be into the bone. And if it erodes into bone, as shown here, it is extremely painful with extensive marrow edema, and it can look like a tumor, such as a chondroblastoma, because of the calcification. And without plain films, when we have widespread calcium hydroxyapatite crystal deposition, as in this patient with chronic renal disease, the MR image can look very bizarre. And you may mistake this for some sort of soft tissue neoplasm. So that's why I say plain films are really critical for accurate interpretation of the MR. Now, calcium hydroxyapatite crystal deposition in and around a joint is an interesting phenomenon that was studied in great deal by rheumatologists probably about 25 years ago. Those rheumatologists were from Milwaukee initially, and the disease Milwaukee disease was described. How many of you have heard of that? Right. And that was a destructive process of the shoulder, often associated with rotator cuff problems, looking like this on an MR. The orthopedic surgeons looked at the same process. They called it cuff arthropathy, figuring that the joint space loss related to the cuff failure. The rheumatologist said, no, this was a crystal deposition disease, hydroxyapatite, that led to the release of collagenase that destroyed the rotator cuff. I don't know the answer to this problem, but I can tell you that if you have patients who have this particular shoulder manifestation, there is a chance, although not common, they have a similar process elsewhere. And we have seen examples of polyarticular involvement with hip involvement that is rapidly destructive, and with knee involvement that looks almost neuropathic in appearance. So this process can be polyarticular, and even if it is monoarticular, it can affect a joint other than the shoulder. All right, so keep it in mind. Maybe there is something to the crystals being important in the development of this process. Now, we're going to be hearing a lot in the next two lectures about articular cartilage. So I'm not going to say much here. I just wanted to show one example of osteoarthrosis because I love to find these button-like osteophytes. You know, we all recognize marginal osteophytes, but these are button-like osteophytes that simulate intra-articular bodies on plain films. And yet you can see that they have marrow continuous with the marrow in the adjacent bone. Widespread patellofemoral disease in the absence of femoral tibial compartment abnormality is suggested to be a finding of calcium pyrophosphate disease. It is not specific, but one of the interesting phenomena you see with this can be erosion of the distal anterior surface of the femur. And when you deal with a common condition of osteoarthrosis of the interphalangeal joints of the fingers in elderly women, and those women present then with a single joint or a couple of joints that are markedly inflamed, there are a number of conditions that have to be considered. We all know about inflammatory osteoarthritis as a subset of ordinary osteoarthrosis, but crystal deposition occurs within these joints. The crystals can be hydroxyapatite, they can be pyrophosphate, they can be oxalate, and they can be gout, as it was in this particular case where there was superimposed gout in a joint of the finger involved in osteoarthritis. We'll finish up in the last 5 or 6 minutes talking about tumors and tumor-like disorders of joint. Pigmented villonodular synovitis has a characteristic MR imaging appearance characterized by that hemosiderin deposition in a thickened synovial membrane. It does produce erosions of bone, as shown by the yellow arrows. Often they are marginal, all right? So the hemosiderin is the clue. Here are two other examples of feathery pattern here of hemosiderin deposition, nodular here, large nodules present here and around the posterior aspect of the joint. Localized nodular synovitis, as I mentioned yesterday, is felt to be a family member of pigmented villonodular synovitis. It presents as a nodule, typically in an intracapsular portion of the joint, consisting of fibrous tissue and also sometimes, but not always, of hemosiderin. As I indicated yesterday, the classic site that we see this is in the deep portion of Hoffa's fat pad. And this is a very characteristic appearance that I show you here. Second place that this has been described is pericruciate So this would be second in frequency. The third is in the suprapatellar pouch, but I would imagine that this can occur just about anywhere in the knee. There are two rare disorders of joints that may look somewhat similar, but these two are extremely rare. The first is designated collagenous fibroma, or a desmoplastic fibroblastoma. This is the only intra-articular case that I have been shown. It occurs in middle-aged persons. Typically, the disorder is one of subcutaneous tissue, fascia, muscle, but it may involve joints or bursa. And low signal intensity is the dominant feature of this particular process, but it is extremely rare. The second rare intra-articular process is nodular fasciitis. This typically occurs in a slightly younger age group in the subcutaneous tissue, fascia, or muscle. But there are reports of this occurring in a joint. One of our previous research fellows reported this case of nodular fasciitis within a glenohumeral joint. Idiopathic synovial osteochondromatosis relates to the metaplasia of synovial lining into cartilage nodules that may subsequently calcify or ossify. These bodies may be released into the joint cavity where they become free. What can occur, in fact, is that later they become embedded in the synovial membrane. This is an operative photograph of an elbow joint showing you all of these cartilaginous nodules. Often they are of about the same size. When you radiograph the nodules, you can see variability in the degree of calcification. Some are heavily calcified, some almost no calcification. So what happens is the MR imaging features vary. In this old case, with not a great image, you can see heavily calcified nodules within the glenohumeral joint. So these would be calcified. When in fact they are not calcified or only partially calcified, they're not as dark, and they're on a background of high signal that looks like fluid, but actually represents the non-calcified cartilage nodules. So that can simulate fluid. Idiopathic lipoma arborescens is an uncommon disorder typically seen in the knee. Diffuse fatty infiltration of the synovial membrane occurs, well displayed on MR imaging because of really the typical signal intensity of fat here in the synovial membrane. Idiopathic lipoma arborescens. Another example, on T1, we can see all of this fatty tissue, and when we go to gradient echo imaging, clearly this is fatty. A focal fatty collection is an intracapsular lipoma. This too is most common in the knee. It can be of variable size. This first one I show you was extremely large. It looked like it filled the entire joint, and it did at the time of surgery. Here's another one, also quite large within the joint. These are focal tumors, probably arising from the synovial membrane of the joint. An intracapsular chondroma is an uncommon process, again most commonly seen in the knee. It's a focal cartilaginous tumor. It has a characteristic appearance in the knee because of its location. Generally seen right below the patella on a plain film. It may look like a partially ossified second patella, right below the original one. It can become large, erode the inferior surface of the patella, displace the patellar tendon, but it is pretty well encapsulated and easily removed. A synovial chondrosarcoma is a rare malignant cartilage tumor that may occur in a joint, again, most commonly the knee. It may be related to initial idiopathic synovial osteochondromatosis. It produces bizarre conventional radiographic and MR imaging features. A synovial hemangioma may occur, again, usually in the lower extremity around the knee. The synovial membrane alone, or it's the synovial membrane and bone and soft tissues may be involved. We look for tubular structures, sometimes with signal void, indicating high flow around the knee. In this example, you can see also involvement of bone as well as the synovial membrane. And amyloidosis, which we have seen in patients on chronic hemodialysis, leads to deposition in and around joints. This is one of the tissues that has persistent low signal, here's a lot of it in the back of the knee, on even the fluid-sensitive sequences. This tissue may also infiltrate joint capsules and tendons. This is a characteristic appearance of what amyloid deposition looks like around the hip. It was bilateral in this case.